Yeah. I don't care. I'm going to do what I'm going to do.
It's your podcast.
And you guys are going to take it.
Pause.
That does not sound right.
Pause.
Guys, welcome back to part 2.
Woo.
I'm going to take this opportunity that Nicole now is here and we're recording to let her know there might be a part 3.
Heads up.
Part 1 was so good. And we covered so much. I took notes just so that we can kind of give. First of all, if you're watching this right now and you haven't watched part 1, you need to hit exit, go back to part 1 to why healthcare seems broken, or why does it feel broken? I think that's the name of the episode. I should know that by now. Mm-hmm. And check that out. And then once you finish that, then come back to this and it'll make a lot more sense. Quick recap though, for the ones that did see part 1. In part 1, we talked about why so many ordinary people, especially people from immigrant and first-generation families, struggle to trust healthcare. Today, we're following the money to understand how the system actually works. Before we do that, Nicole, I know you wanted to touch some things. The way that the last episode ended, we were talking about manufacturing. Mm-hmm. But before that, you wanted to touch on the FDA process of it?
Yeah, because we watched it back and I butchered the what phase equals what. So phase 1 is dosing and safety in healthy adults. Phase 2 is efficacy. And then phase 3 is the large scale confirmation of it all. I think I said animal studies were phase 1. Yes. That's pre-phase 1. So that would be, you would have animal studies going to get the FDA investigational new drug approval to continue studying.
So when you give what you're proposing to the FDA that you want to have in the market, they're going to come back to you and tell you go through the test through the animals and then humans.
So you go to the FDA with like animal studies, or it's not always animal studies. It could be, or it might, I don't remember, but there's a packet that basically says, here's what we have so far on this chemical. We want to now test it in humans.
I understand.
And then the FDA says, okay, you've proven that we should continue testing this. And then phase 1, like I said, is the safety and dosing. Phase 2, efficacy. Phase 3, large scale. Make sure the same things we saw in smaller studies, we're replicating. And yeah.
And that's a way to I guess, make it more safe before it's approved to come out to the masses?
Exactly. So you basically put together this packet of evidence that then goes to the FDA and they decide, do the benefits outweigh the risk to allow approval?
Okay.
And then there is a phase 4, which is post-marketing, and they continue to study it once it's already launched in case any other safety signals come up, any efficacy, they're studying it, and they may study it. If it was approved on something in the lab, they may want to confirm the clinical outcome of it as well. So they continue to study it.
Because I do have a question on that.
Sure.
Because some people think that the FDA and these manufacturers they're just perfect. Like sometimes, and I don't know if this is true, correct me if I'm wrong, sometimes they go through all these trials and they come out in the market and sometimes there are some issues. No? And so what if that happens, because unfortunately we don't live in a perfect world, what would happen to that medication or that supplement?
We have FDA recalls, we have safety alerts that come out. So basically if we notice a safety signal in a drug, they'll review all the evidence, they'll take it off the market and require another study. They'll make you withdraw it from the market. Sometimes businesses will say, I'm going to withdraw this drug because I don't want to keep studying it. We've seen enough safety signals. You know what? We're going to just call it. Right. Or sometimes it's FDA mandated. So does that answer your question?
Yeah, 100%. Okay. Yeah, because I think some people, their expectation is that when something's put out into the market and it's FDA approved, they think it's like a perfect, a perfect medicine or a perfect supplement. And sometimes, some of these trials, they only do 1,000 people, or
it all varies.
Depending on what you're going to release or put out there or want to get approval for. And sometimes it's just not 100% bulletproof, screening or process before it gets out there. because some people think, oh, they put him out there. This is the government trying to control us, and do this, and they're trying to manipulate us and make us sick. And you know how it goes.
I do, yeah. So exactly, we continue to study it. Science evolves. So what the FDA decides is, does the benefit outweigh the risk to get this to people who need this treatment right now?
Right.
And then we'll continue to study it. And after years and years, at some point, they probably stop studying it because we know it works, we know it doesn't, we know the safety issues, et cetera.
Excellent. Anything else to that, babe? Any questions? No. So where we left off, I was asking about the manufacturing process, and where I thought, I might be wrong, but this is how I remember it. It was kind of like the dark side of science. And when manufacturers, in the process of finding, I think we were using as an example, an iron pill or supplement, and they find, this is an extreme example, and they find fentanyl in the process of it. But I was getting more to the fact of, how does the healthcare community or machine go from the manufacturing part to deciding that this drug, which can be very dangerous on one end, but on the other end is very effective. How did they get to the point where they say, you know what, even though there's this potential risk, I guess is the best way to put it, how do we still go and deliver this to the masses or to the patients, knowing that there is the high risk that, for instance, fentanyl can become a very addictive drug, and at points it could be detrimental.
I mean, it's lethal.
Right. So
the FDA decides approval, and then from there they could decide that it needs scheduling, which would be where the DEA comes in and says this has addictive potential, so we need to monitor this even more. And there's 5 DEA schedules, one being there's absolutely no medical reason for it, I'm trying to think, what is the Schedule 1, because now things are changing. Any illicit drug that you can think of. No medical purpose. It's very addictive, whatever. Schedule 2 is when you think of opioids. They are highly addictive, but they can be beneficial, so they have to be very, very regulated. So depending on what schedule a drug, if they get scheduled, because you can also be unscheduled, which is no addictive potential, what schedule they get, it changes a ton of regulations in the pharmacy, like how they're stored, how you can dispense them. Each state has different regulations, how you can prescribe them. Some people need certain DEA numbers, like some providers need DEA numbers to be able to prescribe.
Right.
So that's kind of where the government comes in and says, okay, it needs this extra layer. We also have things called REMS programs, which are risk evaluation mitigation strategies. So it's, I have this cancer drug that works well, but can cause this other fatal, lethal event. So in order to administer this safely, you need to do X, Y, and Z when using this drug. And that's like, you have to follow that, and you have to register for, the certain drugs REMS program, things like that.
Yeah. I think part of the question too that I was asking was, because you were also saying that a doctor first diagnoses something before prescribing or suggesting to prescribe fentanyl to somebody, and then it comes to you, and then it tells you they've been diagnosed with XYZ symptom, or was it like they get diagnosed with some type of sickness?
Yes. And then a pharmacist could potentially come in and say, okay, that's how we treat this, and kind of, there's the different things that play into this. The clinical organizations all put out guidelines. So there's like a guideline for high cholesterol, and it based on all of the evidence. Usually what happens is like the American Cardiology College comes together, and they get a task group, they review all the evidence out there, and the cardiologists come up with like a treatment algorithm of what you would recommend when. Where it gets tricky is that every patient's different, right? So you have to take in what other things they have, what other meds they're on, and that's where medicine becomes tricky. And you have to say, okay, we can't use this because of this drug interaction, or we can't do this, so now let's go to a third line option. So evidence-based is really where medicine is what the studies show is how we practice, and as studies evolve, treatments evolve.
Because I do have one question about that, and I would like to understand: is there a balancing act between what the doctor prescribes or suggests to prescribe, and then the pharmacist saying, "I don't know if this is right for this patient," and what that process looks like?
Time. I'm not even in pharmacy.
Well, before you answer that, should the doctor be giving me options? So like let's say for me, for me, I have high blood pressure, right? Sometimes they just say, well, you're going to take amlodipine. Then they don't really say, well, we have this, and that. I mean, I get it. When I think about it, I'm like, well, what do I know? Like, especially me, I don't know anything about drugs or prescriptions or anything like that. Well, why would I have any objection? Sorry, for that. One, this is why I need to bring her with me every time I go to a doctor. Advocate number one in the world. But I do want to give. Let's answer that, and then I'll have some follow-ups to that.
Okay, so the first part of your question was about the pharmacist.
The balancing act between. So if a doctor says, Emmanuel has high blood pressure. Maybe this is a bad example. You give me another one. He has high blood pressure, and I'm going to suggest that he takes amlodipine 20 milligrams as an example. What does it look like when a pharmacist might disagree? Or do they have the power to disagree? And how does that happen? I'm sure there's an insurance side to that, and I can't wait to get to the business side of it. I just want us to kind of come to a closure with this side of it, and then we can get into the money. But if that happens, which from what I understand, I didn't think that existed. I thought the pharmacist just gets the script and that's the end of it, and they try to fill it.
No. The pharmacist reviews your whole medication history, any information that they have, runs drug interaction checks, runs drug checks with comorbidities that you might have. And it happens a lot where then you either call the doctor, message a doctor, hey, this patient has this allergy, you missed it. Let's, I think we should prescribe this other thing. And then in an ideal world, the pharmacist could pen the prescription to the provider, and the provider can just say, yep, we agree, approve.
Interesting. I didn't know that.
We also, pharmacists have something called corresponding liability, that basically if I fill something that any other pharmacist would think was ridiculous and I shouldn't have filled, I can be prosecuted for that.
By whom?
I guess the people, or the board of pharmacy. They always told us that you had to that was corresponding liability was important, and that your butt could be on the line too.
Yeah.
Interesting. I didn't know that either. I'm learning so much already.
That's a good question about who would.
Right.
Yeah.
Right. Because I wouldn't think that the doctor's gonna.
No, it's probably the patient actually, right?
I'm not so sure about that.
know.
I mean, I would. Yeah, I don't know. That's a good question. We could circle back on that part 3.
Yeah, we'll come back to that.
I didn't even know that was a possibility.
Yeah.
So that's interesting. Okay. So when the, I think you already answered this. So when they disagree, they could just pin it back to the doctor, and the doctor could agree, and then they would just go through the cycle again.
I mean, the doctor could also disagree.
Right. And then how do you come to a decision about which kind? Where does the generic and then the non-generic go into that process?
So part of that is state regulation and how it's written. So you can write a prescription, and the doctor can say, or provider, let me say that because they could be mid-levels, right, too, saying dispense as written. That means you cannot substitute it if there's a generic. You have to dispense the brand. And some doctors will do that at times, and that's just, and then it goes to insurance, and that could be a different issue, right? But if a doctor just writes a prescription, the pharmacy will find the cheapest option to fill it with. The generic, if they write the brand, and there's a applicable generic, they'll fill it for that. They can substitute that.
I understand. Is there why not always? Well, I guess they want to go with the cheapest option always.
Always, yeah.
I'm ready to talk about the business.
What's your question?
Let's do it.
Yeah. Look, so I'm going to try to make this as easily processable as possible. I understand it's very layered. Let's start with the high level things. So I have no health insurance at all, and I think this is where Kady is probably the expert in this side of it. From what I see, going with the government side of the insurance seems to happen to be the best option, rather than going with the employer side of it. I feel
In
like
what sense? In terms of coverage?
yes,
Okay.
because from what I see, from the third party purview of it, the government Medicaid, for instance, it seems to cover a lot more than our employer sponsored insurances. So I guess let's start from the high level of it, and like I guess that would be the step one of the cycle of the healthcare system when it comes to the business of healthcare. Is a patient has no health insurance, and they want to make the best educated decision on what is the best path to go. I mean, if you're working, I would imagine you're out of luck. You have to get the employer.
Not always.
Okay, so let's start there. Like I have no insurance. What are my options? And then what are the differences with health insurance?
Well, I'll start with saying, because you have Medicaid or government sponsored insurance, that does not mean that you're actually getting better coverage or more coverage than someone that is getting employer sponsored health insurance. I think that's one of the biggest misconceptions in healthcare, is that people with government sponsored health insurance automatically receive better coverage. Not true. And I think that the reality is much more nuanced than one might perceive or think. Employer-sponsored insurance and government-sponsored insurance, they're designed for different populations that have different funding structures. Government-sponsored insurance was created to provide coverage for folks that are disabled, seniors, low-income families, versus employer-sponsored health insurance. You contribute through a payroll deduction. Do you get more coverage with Medicaid, or that of an essential plan, or a Child Health Plus plan, or a qualified health plan with an advanced premium tax credit and cost sharing reductions? No. You still get medical, dental, vision coverage, but Medicaid was designed so that you are providing low-income families the 10 essential health benefits, health essential benefits, right? Yearly physicals, dental vision, emergency services, behavioral health benefits. I'm probably going to forget the other 5, like if I was not just training this morning. But outpatient surgery, inpatient surgery, things of that nature, right? So those are the, part of the 10 essential benefits that you get with Medicaid. What there did I say is not covered by employer-based health insurance? Nothing, right? The same benefits that you get with Medicaid, you get through an employer-based health insurance. You're just paying a premium. The thing is that Medicaid, again, it was once again was created to help this specific population. Another misconception is that, or another point of controversy, I would say, is that a lot of people say, well, these folks don't pay into the system and they get free Medicaid. While sometimes that may be true, most times it's not, right? If you work in a pharmacy, if you work in a customer service, role like a supermarket or a grocery store, if you are self-employed and you're reporting to the government, what you're making, you're still paying taxes, right? You're still paying towards that. So most folks, they're paying, whether it's, whether we're paying more than them or they're paying more than us, they're still paying into the system. In fact of the matter is that God forbid we lose our jobs, right? And we have a hard time finding something, or getting back into the work field, we would find ourselves in that position as well, where we're seeking out this type of coverage. So do they get better coverage? No, they just get free coverage based on their circumstances.
On paper.
No, they do. we're getting the same coverage. The only difference that we really have between the two is that with that of an employer sponsored health insurance, and depend on the type of coverage that you have or that you enroll into, you have a bit more flexibility. For instance, Medicaid works as an HMO plan, which means more of a case managed care plan. You need referrals, you need to have a PCP, things of that nature, versus employer-based health insurance. It's, you can choose that route, an HMO route or a PPO route, which the PPO route allows you a little bit more flexibility where you can see physicians in and out of network. Versus an HMO plan, whether it's through an employer-based health insurance or not, you are still, if you choose to go the HMO route, you still need a referral. You still need to have a PCP on file, because your PCP is who's going to be providing you the referral to begin with for you to see these physicians. And if you decide to see a provider outside of your network, then you are going to be held responsible for, to cover the services rendered. And that's the same way that a Medicaid plan works, is based on an HMO structure. So really the only difference is, can I or can I not see a provider out of the or really out of the network, because you're always going to see a provider in network, but can I see a provider out of the network? That depends on you if you want a PPO plan or not. And then in that case, you would pay a little bit more. So really it's cost difference when it comes to an HMO versus a PPO, rather than that of, Medicaid people, they get all the benefits. They do get the benefits, but so do you. You're just paying for it versus a community or a population that can't.
Because the way that I've seen it, and at least this has been my experience, I felt, maybe it's just a feeling then, that employer-based insurances seem to be a lot more limited because the employer picks plans that are crappy.
You are making the point that I was going to make. That when we're talking about like the commercial sector and employer-based, people often hate on the insurance company, right? Mm-hmm. Like, how could they not cover this? How could they not do this? The insurance company offers your employer a suite of products of insurance. This is what your employer picked.
Yes.
So if your employer if your insurance doesn't cover GLP-1s for weight loss, like we were talking about, they don't cover Wegovy, Zepbound, all of those, that's because your employer chose not to.
Right. She literally took the words out of my mouth.
I actually knew that.
Yeah, I'm impressed you knew that. Honestly, most people don't.
No, because the person that I go to bitch or moan about this is HR mostly.
Yes.
I am so informed.
Yes.
Yeah.
But that's why I feel that on paper or in a general sense, it seems, because that's the best way I could put it, it seems that Medicaid seems to be the better route, because although it's restricted into the HMO system, look at me using abbreviations,
jargon.
Mm-hmm. Even though it's in the HMO system, it seems to be more, what's the word I'm looking for? Broad, because it's automatically you're getting dental, vision, although it's a longer process for you to get it to a specialist, and sometimes a longer wait as well, but you're getting it. You get what I'm saying? While the employer-sponsored one, we don't cover this, we don't cover that, we don't cover Then I go back to the employer and I'm like, dude, I'm paying $700 premium a month, which is probably high, but I don't think it's that abnormal. Mm-mm. Or $350 a month. I think it's like, I don't know what the average is, but it's definitely a lot.
That is the average for one person.
Right. Like I remember paying like $350 a month on the premium, and all it really covered was my annual visit. And God forbid I went to the ED, I'm going to drop at least, I was going to say $500.
Oh, that depends on the level of coverage that your employer decided to pay into, right? So most employers, they pay anywhere between 70 to 90%. And then whatever is left over, you pay for. So they'll invest 70 to 90% of the premium of that insurance. And then you will be held responsible for the remainder of it.
And it kind of like you were saying, it depends where. So government-sponsored insurance, Medicare, Medicaid, the government can regulate that, right?
Yes.
The commercial employer sponsored, there's a lot less regulations.
Correct.
So we talked about value-based care a little bit. The government sponsored is already moving towards that, right? They're able to put those things into regulation and say, I'm only paying for outcomes, et cetera. Commercial takes longer to get there. Commercial does usually follow Medicare. It just usually takes longer to get there.
So just to answer my question, so the money starts with, so if I go the private route, which is the employer sponsor route, it starts with my employer sponsoring whatever percentage they feel like they deem fit to cover of my insurance. And then I'm covering the remainder for the premium.
Yes.
That's where it starts for private. And then for the Medicaid end of it is our
that's
our
yes
taxes.
and no, by the way, because again, you can decide to go for private insurance. Most of the time, yes, it is employer based or employer sponsored, but there are times that you are just paying for that private insurance.
100%?
Yes, that's an
Jeez.
option. You know, there's folks that they're working for certain employers, and you know, depends if they are a small business, they don't necessarily have to offer health insurance, right?
Right. So a lot of my entry level jobs, they did not offer insurance at all.
Right.
And then I was stuck in a situation where I don't know if you guys remember, there was actually a time where legislation was actually put out there that if you didn't have insurance, they hit you with a fine. I used to opt, and God, thank you for protecting me, to just pay the fine. I used to just pay I think it was $200 or $500.
Yeah, that was
fine.
around the Affordable Care Act.
Right. So
creation
I
or
opted
launch.
to that because I found that and mind you, I wasn't making like money. Like these were entry level jobs. Like I wasn't banking.
Right.
But when I went to and I want you to speak a little bit on this. When I went to the marketplace, the state one, because there isn't a federal one, right?
No, it's per state.
Yeah, per state. So I went to the marketplace for the state, and the bronze insurance coverages were bonkers. Like I was talking about like $700 premium a month, and then the coverage wasn't that good. Why is it that way when I'm a working citizen of the state? Why is it that, and this is why a lot of people feel like, you know, the government sometimes is working against you. It's just not incentivizing you to be productive. I don't like to get it too political, but it is what it is. This is how I felt, at least. Why was it so hard for me to get insurance as an entry-level worker when there's people that aren't really necessarily doing their part to work? Like, and again, I was like, I want to say I was like at 35,000 a year, between 35, 40, definitely not over 50. I was around that range, and which is very entry level, but they were hitting me over the head when I went to the state. Like I went to I went Health First, Oscar, everything you could think of. And I was like, this is not something that's viable for me, where I can, one, be independent or have a comfortable life and have decent, because it was bronze or nothing for me. It wasn't even silver or anything. I would love to get the diamond or platinum. But so why is it that way? And is there a way to fix that?
So again, it is state regulated, and it is based on your income. So there's not necessarily a way to go into the system and say, you know, well, let me just move a little bit, you know, some numbers and see if it'll make more sense, because that's called fraud. So you don't want to do that, because again, it is income based. Judging by the time frame when the ACA had launched, Affordable Care Act had, you know, been made official, it launched, you know, you have to choose a plan or you're going to be held liable, or you have to pay some sort of, you know, penalty for it. Going back to that time, you were still being provided an advanced premium tax credit, right? That advanced premium tax credit was based on your income. You can use as little as you want, or you can use the entire amount that they provide you. That said, the QHP plans, the qualified health plans, which is what you're referring to, they are broken down into 4 different metal plans and a catastrophic plan. It's bronze, silver, gold, and platinum, and then catastrophic. Now, I'm pretty sure that when you process that application and you were looking at that bronze plan and it's charging you $700, there's a little slider that you have to move all the way to the right so that you can use all of that advanced premium tax credit they are providing you. Failure to do that, you're going to see the full price of that plan, right? So I'm sure that's what you were seeing, because typically with the bronze plan, you're paying little to no money, but you end up paying for that later. So with a bronze plan, yes, it is typically, full blown a good $700, give or take. And if you decide to use the entire advanced premium tax credit, let's say in your case, you were provided $699 of an advanced premium tax credit, then that bronze plan will go down to $1. Right. However, this is the kicker. And this is why you felt like, okay, so there really is no option. And this kind of sucks, right? Because while the monthly premium is $1, when you go into the plan benefits to look at what
the deductible.
Yeah, well, yes, the deductible. The deductible we're talking about, it's about $6,000 to $8,000 a year.
100%.
Okay. Before the plan covers you at 100% with your copays, you have to cover that $8,000, or you're just going to keep paying for those office visits until you reach that deductible. Once reached, then the plan kicks in with your copays. If there are no copays, then the plan pays you at 100%, right? So you probably didn't move that slider to the right, which is why that advanced premium tax credit wasn't being applied, because judging by what you were making at that point, you would most certainly qualify for an advanced premium tax credit. Problem is that you would have chosen a bronze plan, you're paying $1, and then your copays look like $500 for an emergency room visit.
Right.
$95 for urgent care, $75 for a specialist, $60 for your primary care physician.
I think for me specifically, I want
no dental vision covered, by the way.
Exactly.
Because that's a different plan. If you wanted to have dental vision coverage, you're looking at a different bronze plan that included it. And now we're talking about a higher premium.
Right.
But that doesn't necessarily mean that under the bronze selection or options, right? That doesn't necessarily mean that the copays are much less. However, the lower the monthly premium, the higher the out-of-pocket expense, and vice versa. The higher the monthly premium, the lower the out-of-pocket expense. And yes, when we're talking about platinum plans, you're paying about $6, $7, $8, $9, $1,000 to $2,000 a month for a platinum plan. But those copays and the patient responsibility is zero.
Non-existent, yeah.
Right. And we're talking about medical dental vision coverage.
This is crazy.
Yeah.
I think what I did when I was on the page, which was extremely hard to navigate, because sometimes I feel like I wasn't like even filling it in correctly.
Which happens. And
I definitely wanted dental. I remember that. I wanted dental, and I wanted my deductible to be only like about $1,000. I think it was $500 or $1,000.
Definitely not a bronze plan. Absolutely not a bronze plan.
It wasn't mine.
Yeah, it's certainly not. And in fact, I don't think I've seen a silver plan with a $1,000 deductible. I've seen a gold plan. And it is difficult for folks that are not exposed to these plans on a daily basis, because there are certain plans. I'm not going to give names because I'm not sending members your way. Petty. No, but
unless they sponsor this
episode, and then we'll talk. But there are certain plans that, my hat's off to them. They work with the member, and it's a very smart way to grow membership as well, because we're talking about silver plans. Instead, what they do is you're paying about $200 a month for a monthly premium. Of course, this is all depending on the advanced premium tax credit that you get approved, what your yearly income is, so on and so forth. Excuse me. And so what they'll do is they'll charge you about $200 to $250 a month. Your copays would be about $30 for a primary care physician, $40 for a specialist, flat. So this is not after you reach the deductible. This is just flat. So you don't have to worry about reaching the deductible unless you are going for, other services such as outpatient surgery, inpatient surgery and admissions. After a certain, your maternity care is included. there's, once you give birth, they'll charge you like a 10 to 20% coinsurance for the first day, and then everything else after is covered. Dental is covered for your routine services with a $35 copay. You're looking at a 20% coinsurance if you need something more, something more like a surgery or some sort of intervention that, within the dental realm. And then same thing for vision. You have glasses coverage up to, I think, like $250, things of that nature, right? And then a $35 copay for routine vision, right? So those plans, some folks, they at first glance they're like, ooh, $200 a month, that's a huge expense. But at times you have to kind of pivot that conversation and say, so let's break it down, $50 a week, is that something you'll be able to do? And so they sort of think about it that way and say, well, yeah, that is feasible. Well, that is the $200 a month. And this is what you're actually getting for your coverage versus you paying $1 for a bronze plan and then you're having to come out pocket so heavily when you're going to your doctor's office. The only thing that's covered throughout all plans, and this is state regulations, I believe it's also federally regulated, is your annual wellness visits. Those are included in all plans. No ifs, ands, buts, or coconuts. They're included in all of them. And there is no cost sharing. So that is at zero deductible, zero copay. That's included in all plans. But when you break it down like that to a member, it's easier for them to understand, because when you go in there, like you went in there, you were like $700 for a bronze plan. This is absolutely absurd.
I paid the fees, the fines. I mean,
yeah.
I was like, heck no.
Many people
There's no point. There's no point. And luckily, I was young or younger.
Right.
And I didn't had any, like, in my mind, I was like, you know what? I'm healthy. I'm not going to get sick, And if I do get sick, and I know this is a horrible way of thinking, I would just go to the ED and then what is it called? The fund that covers you when you don't have any insurance?
Oh, that's just
is that just a state fund?
No, that's every hospital. I don't even should say this because
you don't have.
I'm not even gonna say it.
Yeah, that was just my mentality at the time. I was like, you know what? May the Lord cover me, and if I needed to go to the hospital,
then let it be what it's gonna be. I mean, you're still gonna get billed.
Yeah, they hit me. I think with $500.
Yeah, you're still gonna get billed.
I think what you're describing is being underinsured, right? So you have insured, uninsured, and underinsured, where you have insurance, but you still can't really afford your health care.
Right. Well, I ended up being not insured at that time. Mm-hmm. And I think that's what's happening a lot with a lot of Americans out there today. And to bring it back to, the first generation, which is who we talk to the most, we come, our parents tell us, you're going to go out there, you're going to work. And then we want to get something back in return for putting our efforts out there. And we don't, when it comes to healthcare at least, and we find ourselves in this horrible situation where we don't know what to do. And luckily, a lot of us, like, I remember growing up, I was able to get into under my father's employer's insurance until I was 26 as a college student. I think
26.
It was.
That's the
max. Is it like?
Yeah, it's 26.
It doesn't matter if you go to school or not.
No, especially if you go to school.
Right.
Yeah.
So I know I was going to my short run in university. My little LaGuardia Community
That's
College.
okay, because I think school is a scam unless you're going for pharmaceuticals, medical, STEM. That's where I draw the line, right? I think so.
Yeah, for me.
Is that what I told you? I told one of you.
For me.
Yeah.
STEM.
Yeah, I think it's a scam.
So there's, I can go both ways, because the thing is that if you don't use your insurance, let's say you are paying your insurance, whether it be the Medicaid side of it or the state side of it or the employer side of it, when you pay your premium and let's say you don't use your insurance, where does that money go?
That's a good question. People think that it's like it sits in a pool or something. But in reality, that money actually, it goes to cover claims for other folks, to business at the end of the day. So it's not just, I mean, I don't like to necessarily call it a use it or lose it, but in a sense, insurance's purpose is to manage risk. Right.
So your premium is going to be different than my premium based on our health conditions and what they underwrite us for. And then you are managing your risk, and the insurance company is hoping that the claims that they paid out are less than the money they've collected.
That's tough because
It is.
then essentially men are going to have to pay more when it comes to insurance, no? Because we tend to have more dangerous jobs, no? Like construction, like let's say I'm a construction worker, my premium is going to be a lot more expensive than someone that is a cash register, like working behind a cash register.
That's so interesting. I didn't think of it as occupation. I was thinking of more of like what diseases you have.
Yeah.
But I don't, they may take that into consideration too. I don't know.
But are you referring to employer-based health insurance as well?
Either or. I would, in that sense, I would think that the employer-based one is cheaper than the state ran, because once I tell them my occupation, then I would think that the insurance company is going to run up my premium, no? Because I'm a higher risk to have to use my insurance, no?
I don't think so, because you would have like workplace benefits, right? Like potentially there'd be workman's comp or whatever. I honestly don't know. That's an
but
interesting point.
Workman's comp would come in to play, if you actually have an accident while on the job, and then they'll cover while you're out and those.
Right. So your health insurance wouldn't cover that, right? Then
not if you're on work. I mean, if you had a work-related injury and you have workman's comp, workman's comp covers that.
Right.
But if you have employer-based health insurance as a construction worker, again, that plays the same part, right? So if your employer decides to pay 70, 80, 90% of the insurance, whether or not you're a construction worker, you're still held liable for the remainder. So if it's 70, you're paying 30, 80, 20, 90, 10. Or, I mean, if they are gracious enough to pay 100% of it, more power to them. But that doesn't change, what coverage you get through your insurance or insurance carrier based on you being a construction worker.
Interesting. Okay, that makes sense.
You would probably have a deductible. You reach the deductible the way anybody would reach the deductible. And then once reached, then the insurance covers you with either your copay or, if there is no copay, at 100%.
Right. That's very helpful, everything you guys said, because in my mind, it did seem like the Medicaid route seemed to be the better coverage.
Yeah.
But and I do feel like there's a trend. I feel like employers they're not going towards the cheap end anymore of insurance. I think people have caught on that the benefit packages are just important as salary, and people are like, if you're not covering 100% of my insurance, there's 10 other companies that are willing to do that for me and give me unlimited PTO. You know what I'm saying?
Yeah.
And I feel like the trend for that has definitely changed. I feel like when we were younger, it seemed like more of a blue collar market per se. And it was more about the salary. Like it was more, we're going to pay you. Now, especially with millennials, I find, and dare I say Gen Z, I think they go too far, if you ask me.
Yeah, they go too far. Just a sidebar. I mean, did you guys not read the article where these guys are really bringing their parents to interviews?
Yes.
Nicole, I will send
Wait, I
you
don't
the
know what you're
article.
talking about.
I will break it down. Gen Zers, I believe it was, I want to say 60%. Don't quote me on the percentage. I'm going to send you the articles, plural. There's more than one, where they're just not with it. They're not with the crap. They are just like, it's too hard for me. It's my mental. I can't do it. I'm going to call my mom type thing. Where they are actually, applying for jobs, and not all Gen Zers, but mostly all. They're applying for jobs and they're bringing their moms or their parents to the interview.
Wow.
Yep.
Yeah.
It's a thing.
It's a thing. I hope it was a thing.
Well, I think that's why and not to get off the topic too much.
Yeah, it's a
there was a wave of Gen Zs, like they started getting let go because
yes,
that's another podcast.
that's another podcast.
That's a different
another
podcast because we could really literally
yeah
get into
it's
that.
another podcast.
But I do have one question. Does Medicaid? Well, so I think, did we answer the question? Where does the money go if someone doesn't use?
Well, yeah. So I started to answer it, but so again, it's like almost a use it or lose it kind of thought process around that. But if you are paying a premium and you're not necessarily using insurance, those funds are used to pay healthcare claims. And that's for members who need care. But they're also used for to cover administrative costs, maintain provider networks. They invest in care management programs. So it's not just, as executives, we're just going to pocket the money. They're used for the actual, insurance realm in all that entails. So it's not just, it sucks to think about it as, damn, I'm paying for health insurance and I'm paying a monthly premium, but I don't really use health insurance. And in that case, and I can go down the rabbit hole with you with this, in that case, just pay the lowest possible monthly premium option in your job, like a high deductible plan, because you only go typically for, for someone like yourself, for example, you barely go to the doctors. You literally go for your yearly physicals and you go every 6 months to your cardiologist.
That.
I mean,
now I'm going every 6 months.
Because I'm scheduling the appointments. Right. But
get you a wife, guys.
but but someone such as yourself, right? You're only going to 3, maybe 4 appointments a year. So you would benefit from a plan that's high deductible, low premium. And I'm talking about like $50 a month or per pay period. Like a every 2-week type of thing. Like if you get paid bi-weekly, you're paying $50 on a bi-weekly basis, $100 a month. But your deductible is quite large, right? It's really, really, really expensive. But again, you would benefit from it because you're not someone that typically goes to the doctor's office. So, I mean, if you're going to eat $50 in McDonald's anyway, every 2 weeks, just pay it in insurance, right? Just cover yourself in that area. And then you just pay for, the doctor's visit. It's not going to be like a $1,000, $2,000, $3,000 office visit because there's also a cap. But you would benefit from something like that. So if it's for someone that barely goes to the doctor's office, get a low premium, high deductible plan. But if you are someone, so that it doesn't hurt that much when you're thinking about, oh, well, I barely use insurance. Now where is all of my monthly premium going to? It's still being used for good, right? You're still talking about, again, care management programs. It's going to provider networks. It's going to, to cover other claims, within the network of folks that have that insurance and is using, so on and so forth. So it's not like a huge thing of, oh, well, I'm just wasting money, because it's still going to good use. And you might need it too. Like, it's basically like, it'll go to, it's almost like it's spread into different categories within
like buckets. Different buckets.
Right. Yep.
That's interesting. So I wanted to see, like, I lost my train of thought. I was going to say something literally about that. So, because in my mind, I thought employer-based insurances was its own bucket, and then Medicaid was a bucket, but that's managed only on the state level. Is that right?
Well, what do you mean, like a bucket?
So, like, all the premiums, they go into that bucket. For Medicaid, it would be our taxes, and then the federal government allots a certain amount of that to the state. And then for the employer side or the private side of it, everybody that's an employee in that employer-sponsored plan, they would pay their premiums into the bucket of that company.
I'm still not following.
They're really different things. You can't think about them as similar, right? So I would say you have commercial health insurance or employer-based sponsored care that is paid for through percentage of the employer, percentage employee, right? For government, there's Medicaid and Medicare, and so you're getting at where does that money come from?
Where the money goes. So when we pay our taxes for the Medicaid and Medicare part of it, it goes to the federal government. So that's the easy part. On the private side, I thought employees as a collective paid into the bucket of just that. The bucket was just for the company. So the monthly premium would be a bucket where all the employees from this said company would pay into, and then from that bucket, it would come back to cover the employees of that company.
Well, remember that.
Or does it go to the insurance company, and then in return, when you use insurance, that's the way they pay for it?
Well, yeah, think about a monthly premium as a membership. If you stop paying it, you don't get it, right? You stop paying the gym, you can't go to the gym until you pay that monthly premium. It's the same thing with an insurance premium. You're paying a monthly premium to keep your insurance active. That's literally what the premium is. And when you're paying your monthly premium, it is going straight to the insurance carrier or your insurance provider. And that is literally just to keep your membership going. Everything else comes after. Deductible goes into your medical care or the services rendered. Same thing with the copay, co-insurance, all that good stuff. But the premium is just to keep the insurance active, and it does go directly to the insurance carrier.
Okay.
And
So-
it just to
sorry.
add on, no, it does. It matters what type of what type of agreement the employer and the insurance company have.
Yes.
There's different types of insurance
Yes.
where there's like administrative only, or there's they pay as they go, or they pay per member per month. Like there's a lot of different ways that money can be paid.
That makes sense.
Yeah.
That's great. So why is it different when you have Medicaid? I'm going to keep bouncing back and forth, and I want to get a prescription for what's something common that people get? I get let's say I'm Lodipine
Ibuprofen.
or ibuprofen. That's fine. Why would it be the way that you dispense that different from government insurance than private commercial insurance?
In what sense?
Or is that a thing? Because sometimes I feel like the government sponsored insurance always gets a generic prescription,
Oh, that's a good point.
and then the commercial always gets the non-generic,
The brand.
the brand name. And so why does that happen?
So that all depends on what contracts the manufacturers and the insurance plans have with each other for what drug is preferred, what's not. I wouldn't, when it comes to Medicare and Medicaid, they are negotiated at like a bigger level. So they're usually more consistent that like they'll always prefer this or that. Where in the employer sponsored space, it's going to totally depend on whatever contracts they've made together. So, and I think the other thing I want to call out too is that there are separate insurances for medical and pharmacy. I don't know that everyone knows that.
Yeah, that's a good point.
But like when you go to the doctor, when you're in the hospital, that's your medical insurance, right? Then there's pharmacy insurance that's prescription drugs only. And they're billed completely differently.
yes, they are.
Oh, I didn't know that.
Yeah. So pharmacy is billed on what we call an NDC, or what the drug like identification is, and that's based on the drug and the cost and the pharmacy and blah blah blah. And then there's your medical benefits that's based on like CPT codes, so your diagnosis codes. And that what's interesting is that pharmacy benefits happen in real time. I submit the claim, I find out if it's paid or not. Medical benefits do not. They're about 3 to 6 months delayed usually. So you are not seeing the claims until much later. So it's harder to kind of navigate that.
So does that feed into why we see that doctors don't want to sit with a patient? They just want to be in and out with patients, because the only way you can survive financially as a provider, which comes back to that volume part where the care has to be in a way, which is why I feel like it's cattle. I feel like a cattle when I go to provider, where it's just in and out. What do you have? Let's do this, and then you're at it. It's a revolving door when it comes to healthcare here.
I think part of that is they're just overworked and tired, period. I think another part of that is it depends on like the sicker the patient, the higher the reimbursement, right? The higher the more severe a code is, the higher, or the more codes you have, the higher reimbursement. So I guess it's kind of both.
How do we fix that? I want to get to solution based eventually, and I already have a question with the premium side of it, because how is it possible to get to a point? I'm going to get back to that point. Is it possible that we can start, or government or private insurances could just start offering plans where we have more options per se with the coverages, so that we can mitigate the price or the premium for the insurance.
What do you mean more options?
So I know that I don't have, I know that in my family, cancer doesn't seem to, to get diagnosed in my family. So I don't want to get coverage for that, as an example.
So like a la carte coverage. Like,
Right.
can I have coverage for diabetes but not for this?
Right.
Well,
To mitigate the premium.
sorry, Nicole, go ahead.
There's essential health benefits that have to be covered by government regulation.
And that would be part of it.
Right.
Yeah.
So can we make it so that insurances cover the bare minimum that the state regulates, for instance, whatever the suite is, and then from there it just becomes optional. I don't want vision, but I want dental. I don't want to be covered for...
But that is an option,
I'd say
actually.
that's how it is now.
It is.
right?
That's exactly how it is now.
So why is it so expensive?
Because insurance is expensive.
Healthcare in general is expensive.
No, healthcare
because,
in general is
You know why? I
expensive.
think the best way to describe why is it so expensive, it's like 6 different industries
Million
duct taped
percent.
together.
Together, yeah.
That there's no... Yeah, it's and it's not a normal market. It's not a free normal market, right?
Yeah.
The patient doesn't know how much they're going to pay until the end. The patient doesn't even know what they're supposed to get, right? The doctor decides what they're getting. The pharmacy has a contracted rate for what to pay this medication, but then the insurance has a different rate of what they would pay the PBM. It's very opaque.
Yeah.
And it's very complex.
It is. And everyone is going to pay for health insurance. People in Europe think they don't, except that is exactly why you bring home about 50% of your check. Don't quote me on the percentage.
It's definitely up there.
But it's up there, right? Because you're not paying it outright the way we do, but they certainly do pay for it, with how much they get taxed. That's going into your healthcare, right? To your question, though, or the point you were trying to make, yeah, I can choose if I want to just go with medical, if I want to enroll in dental, and if I want to enroll in vision. Like to Nicole's point earlier, she mentioned that, pharmaceuticals or, the pharmaceutical end of, or the pharmacy benefits part of the insurance is a separate, separate claims, is a complete separate entity than that of medical, right? Same thing with dental, same thing with vision. I have one insurance for my medical, I have one insurance for my dental, and then I have one insurance for my vision care.
And then a separate for your pharmacy.
And then a separate for my pharmacy.
Not all medical and pharmacy are the same business.
Correct.
That's where it gets really tricky.
Very
is that
tricky.
You have, X for your medical and Y for your pharmacy. So do those claims talk? Can they see what each other's covering? That's where it gets really, really complex.
And same thing for Medicaid. People think that, Medicaid has medical, dental, vision coverage all together, but there is a specific entity that we contract with, for dental. They manage those dental benefits. We also have a contract with a different vision care provider, right? And then we have another entity, depending if you have an essential plan, if you have a Medicaid plan, if you have CHIP, there's an entity that manages those as well. It's either NYRX for the state, the state if you have Medicaid. NYRX, that is who is going to be managing your Medicaid pharmacy benefits. If you have essential plans or if you have, CHIP, then those are completely different departments that manage those dental and vision benefits. It's not just, Health First, Fidelis Care, Molina Healthcare, Oscar Health. They all have different departments, different entities that manage those benefits. And you can decide with the exception of Medicaid, because again, it is part of the 10 essential benefits. It is going to be included as part of your coverage. I mean, thankfully, because again, we're talking about a population that can't afford, regular healthcare, or not regular healthcare, but employer-based or just, what's that word? It just escaped my mind. Premiums, like going for insurance on your own and getting your own private insurance, rather, is what I wanted to say. But when it comes to us, we have a choice. Do you want to add on the additional benefit of dental and vision? And typically they don't run very expensive. I, for one, pay like $14 a month for vision in addition to my medical. My medical is the most expensive part. But I do also have a PPO plan, which again gives me not only the flexibility, but I'm paying for that flexibility.
An interesting call out too. So when you think medical plan, right, you think hospitalizations, you think seeing the doctor, things like that. To complicate this even more, some medications are billed on the medical benefit.
Yeah.
So think about if you go to your doctor and you get like an infusion in during your visit, that then gets billed under medical, not pharmacy.
Medical, correct.
Potentially.
Why is this so complicated? Like it doesn't make sense to me. Like
It's complicated if you're not in the realm.
no, because in my opinion, and I think this is why a lot of people are like, the whole thing needs to get an overhaul. It should be a lot more streamlined, in my opinion. It should be, I mean, it's hard because I think it'll unemploy a lot of people, I guess, because at this point the machine is so big and it employs so much people that it's really complicated and hard. If I was a legislator, to be like, you know what, we're gonna undo the whole thing. We're gonna have 7 major insurances, which obviously you can't do that. I would imagine that's illegal.
I mean, coming from the health insurance side, though, I think that it is pretty streamlined for the most part. I feel.
How?
You know why? Because I'm thinking about, oh my God, I think about just a customer service area of my company, for example, and Lord have mercy, they do a lot. Right. They do a lot. They answer a lot. I can't imagine throwing more on their plate to talk about, claims for pharmacy, dental, and vision and make it an all-in-one. These different entities make it much easier and quicker for claims processing, for member engagement, answering questions, customer service as a whole, right? But I think specifically and most importantly for the claims processing, that is actually one fun fact and annoying fact is the claims processing itself, especially when it comes to Medicaid, to the Medicaid side of things, everyone knows, like, I feel like this is at this point is like universal, that claims for Medicaid are not processed as quickly as private insurance, as employer-based health insurance. They take a while. We're servicing millions upon millions upon millions of members, right? And so it's a lot and it takes a while. And providers tend to disenroll, close panels simply because of claims and how long they take to process. So
is that why a lot of good providers refuse to take Medicaid and Medicare?
Part of the reason. The other reason is reimbursement rates.
That's interesting.
Yeah.
How does the government come up with the rate that they're going to reimburse for a service?
That's also on a state by state level, or yeah.
That's crazy because sometimes I would imagine they underpay, and for
Medicaid benefits, I will say it's not the same as that of private insurance.
And that's why, again, people are getting under. What's the word I'm looking for?
You're referring to when they go to the doctor's office, it's almost like a revolving door. I come in, yes. What do you need? Get out.
The cattle thing I was talking about.
I mean, yeah, to Nicole's point earlier, I do think that they are burnt out. They are exhausted. It is a lot, right? You're doing this. For example, one of my physicians, love him to death. I think he's like one of the best doctors ever. My OBGYN, that man works every single day. And he actually can count the times in the year that he takes a day off. And still, he's been in this industry as an OBGYN. He's been a physician, I want to say about 30 years now. And still, his attitude is amazing. Like, he is a freaking good doctor. He's a great doctor.
I mean, he's passionate.
He's passionate.
But what he does.
Absolutely. Absolutely. He's absolutely amazing. Love him to death. He's such a good doctor. But for the most part, doctors are burnt out. So I think that also has a lot to do with it. But when it comes to Medicaid physician, I tend to agree. I think that, to keep the doors open, to be able to, make as much as you possibly can, you have to cut the appointment times down to be able to.
Because of the reimbursement.
I mean, yeah,
rates.
It's, people can disagree if they want to,
are
but
double, triple booked
a million %. Absolutely.
I mean, there's also a primary care provider shortage.
Yes, there is.
Because the reimbursement is higher for specialty
Yes.
professions.
Yeah, absolutely.
Right? So a cardiologist makes a lot more money than a primary care physician.
100%.
So doctors are incentivized, or providers are incentivized to go into specialties.
Understood. So, as to look at it from the business side of it, why would I want, as a provider, even, and I would imagine, is the reimbursement rate as bad for a pharmacy as well? Does Medicaid reimburse less for drugs?
Oh, like on the pharmacy benefit, you
Yes.
mean? So Medicare and Medicaid, government sponsored, has totally different like regulations,
Especially Medicare.
Yeah. Than employer based. They are completely different.
Yeah.
Like for example, I think Biden put in the Inflation Reduction Act where you can negotiate drug prices now for Medicare. It used to be in law that the government could not negotiate drug prices. Yeah. So that changed it. So now they can, but again, that only applies to government. That doesn't apply to employer sponsored.
But was it because it was so low? They didn't, a lot of drug or manufacturers didn't want to provide the drugs to government sponsored insurances because the reimbursement was so low?
No, I don't think it, in the pharmacy, there's contracted rates that the pharmacy would get that then pay the PBM, and they negotiate the contract for how much they're paying for that med. So I don't think so. I think that's a little bit different in the pharmacy space.
Because in my mind, oversimplifying everything, because I think I know it all. The reason why the government-sponsored insurance tends to be lower quality, the healthcare side of it, is because of the reimbursement rates.
Well,
for both medicine and for medical.
I mean, on my side, like, what important nuance is Medicare and Medicaid, both government-sponsored health insurance, insurers are paid a set amount per member, and that amount is set by the government. And after
per state.
But remember that every state has different regulations, and they can everyone, they, in order not to go down that rabbit hole and to keep it simple, yes. So insurers are paid a set amount per member by the government and then manage that member's healthcare needs with that budget. Make sense?
Run it one more time.
So government-sponsored health insurance, both Medicare and Medicaid, insurers like them, they get paid a set amount per member by their government. And then they manage that member's healthcare needs within that budget that is set per member, that they get per member. So
yeah, that makes sense.
Makes sense?
That makes sense. So why me as a company or as a provider, why no, so the insurance part of it. Why would insurance want to give coverage to Medicaid patients?
You said why would providers or insurance?
Insurances, sorry. Why would insurances want? How do you make money? That's what I'm trying to understand.
You make money by
if
managing the patient really well and keeping them healthy, so that the set amount that you were given is more than you spent.
Correct.
Right, because
correct.
Health insurance companies, they make money by collecting premiums, right? And carefully managing the costs of healthcare services, which is why it is so imperative that when you sign up a patient, with health insurance, that you also connect them with a primary care physician, because we know that many a times patients go to the emergency department for anything.
Everything.
I have a headache. I've had a headache for 24 hours. I need to be seen. My PCP doesn't have an appointment for 2 days. I'm going to go to the ED. Urgent care is almost like non-existent to folks, right? Wild. If the premiums they collect and investments they make exceed the amount they spend on medical claims, health insurance companies, and operating expenses, they generate a profit. So the moment you connect a patient with a primary care physician, they have someone to connect directly with whenever they're experiencing some symptoms, or they're having recurring issues, right? I'm having headaches every day. I developed a fever. And if it's a manageable fever or a low grade fever, I'll go to my PCP, or I'll call my PCP tomorrow. Enter telehealth. Telehealth has been a game changer, right? Instead of going to the emergency department and spending, God knows how many hours on end, because nurses are triaging patients, and figuring out who is actually experiencing an emergency, hence the name emergency, guys. These people are going to spend hours on end waiting, right? So when they are connected to a primary care physician, they are, they know that they have someone to turn to help them with their needs. And that in turn also saves insurance money.
100%. Because a primary care physician is not going to charge you with an emergency department.
1,000,000% not.
You know what I'm saying?
Especially if you have Medicaid, the insurance, the insurance is not going to bill a PCP, the way they would bill an emergency department, right? And vice versa. So same thing with, employer-based health insurance or private insurance. There's different reimbursement rates, there's different costs. And, naturally the emergency department costs much more, you know? So, yeah, that's essentially how they make money, especially making sure that if you are connected with a primary care physician, that right there is going to help mitigate those costs.
How does it work when it comes to medication, and when it comes to getting paid or reimbursed? Like, how does the business side of the pharmacy end of that work? Because first of all, I didn't know. I thought the insurance provider was the one that did the pharmacy side of that. But how does it end up being that, let's say, for instance, I have my insurance. One insurance might cover or X amount of money for this prescription, but for someone else, it might be fully covered. And you get what I'm saying? Like, how does that work?
So I'm going to kind of give you a macro level.
Yeah.
So there's a drug manufacturer. They set a list price, whatever they want. There's a wholesaler who is like an intermediary, and they help get buying power with the pharmacy. They take a cut, right? That's how they make money. The pharmacy buys the drug from the wholesaler, right? That's one price they pay. So there's like one line. Then you have a patient. Let's say they go see a doctor, they get a prescription. The prescription is sent to the pharmacy. So the pharmacy has already paid for the medication. It's in stock, right, from that wholesaler. They will, they have a contracted rate with the insurance company, which is based on what the PBM has negotiated. So PBMs, if you think about them, they control the drug supply chain. So they kind of give buying power to different insurers, things like that. So they have a contracted rate with the insurance, and they have a contracted rate with the pharmacy. So the pharmacy would submit the prescription, and based on what the insurance covers and the contracted rate, they get paid. And then there's either a copay or no copay with the patient. And that copay is based on what the employer or the government has decided to cover with the insurer.
That makes sense.
Is that?
Yeah. That totally makes sense. Because then it makes it make more sense, at least the math of why it's different rates with different insurances, because the PBMs, right? The PBMs negotiate different rates with different insurances. In other words, what a United Healthcare is willing to pay might not be what a Oscar.
I see. Yes, exactly. And
that's how you get the different bills.
And it's all opaque. No one knows what anyone else,
I would imagine,
is paying.
Yeah.
Is it possible, in my utopian world, one, to remove the government from the government side of the insurance, as in them managing it, and doing the same uniformed way on the corporate side of it, where the government would release control. They would just manage the amount that's going to be covered and give it and let a bidding process happen between all these insurance companies. We're going to give you, we're willing to release X amount of Medicaid or all the Medicaid clients that we have or patients that we have and everyone that's under Medicare, while at the same time regulating how much a manufacturer can bill and a provider in a way that it opens up the masses, that the patients are going to be paying less, the providers are going to get paid more, and in turn, the insurances are going to still make their money. Enough money that it's worthwhile for them because they're receiving all these new clients.
That's a loaded question.
I'm trying to find a solution to fix our healthcare.
So I will say no country does it right.
Yeah.
There's tons of different ways. I would like to tell you about the UK system if I could.
Yeah,
I think
please.
that is a decent example. So there's a single payer system, right? And basically a drug gets approved by one entity and then another entity decides if it's worth paying for and whether it's covered on that single payer system or not. And if they decide the outcomes are not worth the price, they say we're not paying for it, and the manufacturer basically has to decrease the cost of the drug. That gives them negotiating power.
So that's
I would love to see that here. I will tell you, because medications here are just astronomically expensive. Like
essentially that's what I want to do, and that's what I'm trying to kind of portray in the question is, let's get the government out of it. They need to. There needs to be parameters to it, just like the government, governs other things. I don't want to complicate it. So there's going to be rules. This is what's allowed and this is what's disallowed in this market, which is healthcare. We're going to relinquish all control from managing, including the states, by the way. We're not going to manage any of it. We're going to let only private, obviously there has to be a bidding process for all of this, or give the option to the patient to be like, well, Oscar Health is going to they're going to give me the same coverage as United, but they're only charging me X amount of premium, and then vice versa the other way. Does that make sense? So we're opening it up so that the market dictates insurance prices.
that's a slippery slope, man.
No, because again, the government still gets to set the rules. The coverage isn't going to go down because now all these companies are competing to receive the money from the government and the commercial side of it as well. Does that make sense? Like, I'm opening it up for the market and all these private insurances to not only become leaner, more efficient, but also compete for clients while giving great healthcare at the same time.
I don't think I'm following, only because isn't people can shop their healthcare now.
Yes.
So there is competition, right? And that's sort of
Yeah, I mean, there is. There is.
But I think what changes it and makes it is making it more expansive. So the government side of it, and is this already happening? Maybe I'm wrong. Is that already happening where private companies are competing for the government side of the insurance?
Yes, private companies offer Medicare insurance. Is that what you're getting at?
I mean, private companies offer Medicare and Medicaid
Right.
insurance.
So they are administered through private companies.
Yeah. And that actually started to happen, don't quote me, I believe as of Obama's Affordable Care Act.
That sounds right.
Right? Don't quote me on it. I'd have to brush up on it. But that does already happen.
Mm-hmm.
Private insurance does, so they are in contractual agreements where they are offering, and not only just Medicaid and Medicare, if I'm understanding your question
Yeah.
correctly. Not only Medicaid and Medicare, like for example, Medicare with the Part C, Medicare Advantage plans for both Medicaid and Medicare, dual eligibility managing. But they're also offering QHP plans, qualified health plans. So someone that is with Anthem Blue Cross Blue Shields through an employer-sponsored health insurance plan, and someone that is going through the marketplace to choose a qualified health plan with an advanced premium tax credit can also end up on Anthem Blue Cross Blue Shield because they offer those plans as a lower cost option. They get an advanced premium tax credit, which is basically the state paying a specific portion, right, to help you offset the cost of that monthly premium.
Okay.
And that is sent to the insurance plan on your behalf, and then you pay the rest. So the state is giving the insurance plan a specific amount, right, which is the advanced premium tax credit, which you qualify for depending on your income. And the income, the FPL level, is actually quite expansive, right? So it's someone that's making $31,000. Don't quote me on the number. $31,927. They will enter an Essential Plan 1, right? Which Anthem Blue Cross Blue Shields offers, Fidelis offers, Health First offers, Oscar Health offers, and Better by Fidelis Care. I don't know if I said that. They offer these plans for essential plans, but they're also offering qualified health plans with an advanced premium tax credit and cost sharing reductions.
Interesting. Where I'm trying to get to is how do we fix the broken system of it being so expensive?
Oh,
and
man.
I thought, I didn't know that it was already that way. I thought that if somehow we could open it up so that not every, but most people that are signing up for insurance, at least the government side of it, because there's so much money to be made on that end of it, if they just put like a price tag per head, like a budget per head, and then have the insurances kind of fight it out to get that clientele and that revenue, that in turn the whole system would have to kind of like realign itself and then adjust to where it's a lot cheaper.
Yeah.
So long story short, how do we make it cheaper? How do we get to a point where we can get both quality and pricing to a affordable price?
I again think that's
Or
a
rate.
loaded question because there's definitely no magic fix.
Yeah.
The reason why health insurance is so expensive is because a lot of it is connected to it. We're talking about hospital prices. We're talking about prescription drug prices, administrative costs. We're talking about chronic disease, lack of preventative care. And that all plays a part.
That's a huge one, the preventative care.
Yeah.
And I think the way that we're set up today, and this is where the negative side of capitalism comes in, we're not really incentivized to do a lot of preventative care. Because part of the real cost of healthcare in this country is losing out on money.
Yeah.
Like, how many times are people not able to go to a doctor's visit because they can't afford not to go to work?
Yeah.
Or they're going to lose out
Great point.
on overtime. Or I can't afford to, because, the single mothers of the world or whatever it may be, they're just they just can't afford to have, someone watch their kid while they have to go take care of some medical.
Valid.
You don't have transportation. You
Right.
don't. Yeah, those are all very valid things that occur in the healthcare system.
A
all the
million
time.
%. And I think that to fix it, we have to stop only talking about who pays the bills and talk about more why are the prices so high to begin with.
And I think that's what I'm trying to get to the root of.
Why are prices so high?
Yes.
Because it's 6 different industries that all have different incentives and they don't work together.
Yeah.
Can it be regulated to a point where it can get cheaper? Is the lobbying too effective and obviously I'm not trying to get shot out here in this world.
Please don't.
All the powerful people in the pharmaceutical side and in their hands, which is why I always say it all the time. The way that we need to get rid of lobbying is so essential to this, because I truly believe there is a solution to this, but I don't think that the government is willing to do what it needs to do to get this to be more affordable, because they have money in play. The donors, the pharmaceutical companies, they pour so much money into the government and into the politicians that they don't have an incentive. They just, it's greed, obviously, and career politicians feed into that greed. You know, why would I want to fix something or change a legislation that's going to help millions of my constituents when I'm going to lose out on potentially a career of $20 million, as an example? It might be more, it might be less. It could just be insider information and me just putting in some trades and I'm making millions off of that as well.
Right.
I'm just saying I've benefited from it. Not personally, but I'm saying I've benefited on some of the trades because I follow some of these politicians' stock buying and movements.
Yeah.
That's crazy to me.
Yeah.
So is it possible that the government can make healthcare cheaper?
I think it starts with transparency. and that's tough when we're talking about the government. Let's be serious. We got to call a spade here.
Is it more of a manufacturing issue? Is it because we don't manufacture a lot of things in the United States, or is it because the manufacturers or the health insurances bill what? I mean, I think it's more the providers.
You
and
make
the
a good point, because patients should know what something costs before they get care.
Right.
That's huge.
Yeah. So it's not just one entity.
Yeah.
Like, yes, drug costs are high, but yes, insurance costs are high. You know, like I think it's really hard to point one finger when everyone is kind of trying to work the best in their realm.
1,000,000%.
But I do, I think that I don't know if there's a way. I think overhauling it and making it more affordable is like overhauling the system, right? And I don't know what that looks like. I think if it was an easy fix, we would do it by now, right? But like that's probably what I think that's part of what the Affordable Care Act tried to do too. And like that's when prevention had like annual wellness visits. I believe that's when it was annual wellness visits had to be covered, $0 copay, different vaccines, blah blah blah. So it's how do you balance the clinical outcomes and the financial outcomes, and I don't know what the answer is.
It's at the end of the day. At the end of the day, I need to start speaking slower. At the end of the day, is the government willing to be transparent? Is the government willing to have these conversations and include the people in these conversations? To me, the answer is no. I mean, we hear a lot of talk, but we don't necessarily see a lot of action. And like I said, I think the one major fix, not the fix, but one major fix is transparency. You know, and us knowing what we are paying before we actually pay for it. You know,
that's a great take.
Yeah,
because there's no way that I want my insurance to pay $1,000 for an example, an MRI at one place when I could get it for $250 at another provider's office.
You know what I mean?
And like right now, you probably could figure that out, but it would take a lot of work on your end.
Right.
It would be calling different.
And who wants to do that?
Exactly. That it just makes it more complex. Like, who's my preferred? Where do I go? Where is it the cheapest? And there's never there's not a central point where you can go to find that all the time.
Yeah, and it's not something that you can call your insurance carrier and say who's cheaper.
Okay,
they don't know that.
So it does go back to that question that I originally kind of put out there. Yeah. So what if we made it in a way that health insurance worked as a bucket, but to the patient's end of it? In a sense, I'm going to get allotted $20,000 or $25,000, just to throw a number out there, of coverage a year. And if I can mitigate
Oof, if it's just $20,000.
No, but I'm just putting
That's gone with 2 MRIs
Right.
and a CAT scan.
but that's why I wanna see how we can make this a lot better for everyone, or at the end for us, let's say.
I mean, honestly, if I'm gonna be real, not to interrupt you, but and I hate saying this because in my mind, and it's Speedy Gonzalez right now. I'm saying this, but also in my head, I'm also contradicting myself in other points. But I'll say this is, I don't mind right now paying my monthly premium that I currently pay, as opposed to, getting a specific number for me to stick to. Because what's that number going to be like? We know health insurance is insanely expensive, right? And I can see it when I get my bills. I mean, there are hospitals, I'm not sure if they're all, but I've seen it myself where you're looking at the itemized and skin to skin when you have a baby, you're charging me.
I saw a TikTok about that.
Oh, really?
They charge for skin.
I mean, I've seen it on, I'm actually, 2 of my best friends actually just had babies. I mean, one of them just had a baby. The other one had a baby a year and change ago. And I actually want to look at those claims because I have seen it once before. And there is a charge for skin to skin. First of all, that baby just came out of me. And now the baby is on top of me. And you are charging me for skin to skin, make it make sense. You know what I mean? Like and I think there's a lot of hidden stuff like that in your claims. And if you take a moment to look at your claims, you're going to be pretty pissed off.
I've heard stories of people saying that like they go to a hospital that's in network, but the anesthesiologist is out of network.
Correct.
That
Yes.
works at the hospital.
Yes.
So they get hit with bills that
Yep.
way. Like, so I think to your point, it does come back to transparency. And I think in saying that too, right now, what the patient pays is based on the list price.
Yep.
That's different than what every other thing is paying. So like the insurance is negotiating a rate, the pharmacy is negotiating a rate that they,
And I think that's key right there. They're negotiating rates.
right. So they're going to pay this negotiated rate, but your copay or your price as a patient is going to be based off of before those negotiated rates.
Assholes. Okay. So I think we are coming to, at least in my mind, we're coming to. So I think to make things a little bit, to level the playing field between insurances and providers, we should empower patients. So I should be able to go, this is not always going to work, of course, and it's not going to be perfect either. So don't flame me in the comment section. But I think we should get to a point, or we should try out. We should be a trial first to see if this works. We should put a price tag on everybody or a budget on everybody. Hear me out. And let's say whatever the amount. Let's say 50,000. Is that better?
No.
A year?
Not until if you're
give me a number.
Oh God, I don't even know what number to give you because
A
if
generic
we're gonna go
number.
by,
A generic number. 100,000.
I guess.
That's a lot. 100, but let's say 100,000 because what I was gonna.
You know what? Let me Google.
What I was gonna
real
say,
quick.
what I wanted to do was give an incentive is to the patients to do their due diligence. So, as you come up with that number,
Without insurance, an MRI could typically cost anywhere from $400 to $3,500. Complex scans like full body or abdominal, and hospital visits can push that total to over $10,000. Do you see why it's hard for me to give you a number? Because $100,000, that's like, oh, so you're just not going to be going to the doctor's office or to hospitals with that much frequency.
right? That's why I felt comfortable with that number, because for someone like me that doesn't go to the doctor a lot, I'm like 50,000 is a great budget.
But we're in America. What are the odds of that?
Right. So on average, let's throw 100,000 out there, just to throw a number out there. And obviously, there's always going to be an exception to the rule. If there's a major whatever, obviously you're going to get coverage. But what I would like to propose, and I know there's some legislation that you told me that insurance companies have to pay out a certain amount of the premium. Was it like 80%?
Yeah, like 80 to 85% depending on their size. And
Okay.
it has to go towards claims.
To claim. So let's say we're going to allot $100,000 to everyone. That's 80%, let's say. and obviously there's going to be exceptions to this. And we're going
And
to
you're giving it to the patient?
we're putting it yes, we're in a sense we're not giving them the check.
Okay.
What we're doing is that we're giving them that budget. And what we're saying is that if you do X, Y, and Z, we're going to reward you. And I know insurances already do this to a certain extent. If you do your annual visit, they give you, I even have something in my health insurance that every day that I hit 10,000 steps, I get money.
Yeah. Yeah. Incentives.
So they give me incentives. So what if we make it, we incentivize patients even more? We want you to live a healthy lifestyle. And if you live this healthy lifestyle, we're willing to pay out of that $100,000 budget an X amount that's going to be rolled over to a HSA plan. So people aren't going to be out here buying Bentleys and stuff like that with this money, or buying, sneakers or whatever, being, consumers as we all are as Americans. But what we will do is that if you stay within this budget, the amount of money that's left over, and obviously this is not going to work for everyone, because if you're already sick, or you're a cancer patient, I get it. It doesn't work. But if we can incentivize patients or clients to stay within that budget or under that budget, and they can roll over a percentage of that money into a HSA. So when we do get older and our bills become more expensive, everyone can afford it.
That's such a sweet plan.
But doesn't that make?
I think that would be great. Is it feasible?
Not only, and this obviously would only work for the younger population. In turn, and obviously for older folks that are healthier, but again, that's the point. We want to.
Then what do we do with the other?
That's going to be the exception of the rule.
Okay.
So, but long term. So I'm thinking long term. Short term is not going to really make a dent, but long term, I'm saying you're 20 years, 30 years plus, it'll reduce.
I just think it's so sweet because he's thinking, so he trades. He's thinking with his trading mentality.
I guess.
Yeah, he's totally thinking with his trading mentality.
But not only.
I think that would be cool.
No. The incentive is there. You're gonna get money for it.
I mean, I would say that there are incentives now, right? Could they be better? Absolutely.
That's what I'm proposing.
Yeah, because I think another fix is investing more in preventive care or preventative care.
Sure.
The system often waits until people are very sick, and then we pay for the most expensive version of care: ED visits, hospitalizations, advanced disease treatment such as cancer, right? I think that's awesome. I think that that investing more in preventive care would definitely put us in a better position, right? We have certain things that insurance companies do, like they give you these OTC benefits, right? Where you're getting, it's a use it or lose it, right? It doesn't roll over. You get, for example, our Medicaid members get $25 on a monthly basis, and you can buy anything in the pharmacy. That can be lotion, soap, toothpaste, over-the-counter medicine, over-the-counter vitamins. If there are certain food items that are healthy, you can also buy them with an OTC card. So that's one incentive, right? And folks would also get what's called oh my God, it's of course going to slip my mind, and I do this every day. OTC, and it's like the healthy...
the sweat equity program.
That's like your version,
Yeah.
but there's a version for Medicaid members. I cannot believe it. It just slipped my mind. But basically, you get incentivized by, you go to your primary care physician, you get a $15 gift card. You can use that gift card absolutely anywhere you want.
I get that on my insurance.
Yeah, so we do that as well for Medicaid members, dually eligible cover members who have Medicare and Medicaid, essential plan members. They get these, and it does vary by plan.
Yes.
It does vary by plan.
And they make it hard. Some insurance companies make it hard because if I don't sign up for it, I don't get these rewards.
Well, yeah. I mean, yeah.
So if you have insurance, take the time to check it out.
Yeah.
And see if you have a sweat
Gym
equity
reimbursements.
Yes, sweat equity insurance. I remember my city bike was getting reimbursed as well. So go ahead, finish your point.
No, but that's what I mean. I mean, I think that investing more into preventive care, I think that would also lead to an overall betterment of such expensive health insurance costs.
So what I'm proposing
So
isn't,
I see where you're going. I guess I'm just living in reality.
Well, and I guess what I want to say is that I have a friend at work that always says, we're never short of ideas. How do you make that happen?
Exactly.
It's always the operationalization of it that things fall apart.
Yeah. Because
in your plan, I'm trying to think through, like, would that work? How would that work? And I think step one is that everything would have to be on one benefit to just have this set amount of money, and everything would have to talk to each other, right? Doesn't happen today.
it would force transparency, one, because if the power is now on the patient or the client, the transparency of how much it costs to go to you as a provider and you as a provider would have to be listed. And if it may be a different rate per health insurance, that would have to be listed as well.
Yeah.
So if the power lies on me to make the educated decision and to incentivize myself, not only to go to a provider that charges less, or to do things that aren't necessarily needed, because that's the balancing act. That's where it gets a little complicated. Because sometimes if I do need an MRI, and then I'm like, you know what, I'm good, because at the end of the year, I'm going to get, that rollover to my HSA. But I think that's okay because again, you're putting the power on the patient to make more decisions for their health.
I think that's fair. I think where it gets tricky, though, is that the patient doesn't have the medical knowledge.
Correct.
So there's information asymmetry, right? The provider, the hospital, they all know more than the patient. So you're empowering the patient to make these decisions, but they don't necessarily have all the information that they need. Even if the price is transparent, the clinical rationale, they need to work with a doctor to get, I guess.
I didn't get to that part of it, I guess, because I didn't think of that part of it, I guess, because what I'm thinking about is how we can make the whole thing cheaper and to kind of like bring it to the full circle. The reason why I think that would work is because how she mentioned MRI could be potentially $4,500. If the transparency is out there, it forces the market to make it a lot more affordable.
Yeah.
So I wouldn't say no to the specialization. I would just want someone to be more cost effective for me. But in turn, I could be like, forget that. If there's a 20-year-old, an specialist that has 20 years of experience and they do charge a little bit more, I'm willing to pay that extra rate or that higher rate, and then, do everything else that I need to do to make it make sense financially. Does that make sense? So in other words, if you give the power to the patient and you incentivize the patient to save money where they can save money and then go all out where they need it, I think overall it would make the market level. It would level the playing field for the market, and it would lower the price of healthcare while still having a decent return on your investment, which is the provider's quality of care.
I mean, realistically speaking,
Am I being too optimistic about this idea?
I think so.
Why? Why?
Especially when we're talking about putting a lot more on the patient. To Nicole's point, that not having medical knowledge, or especially with you men, to get you guys to go to a yearly physical, you're going to require a wife,
But isn't that a good thing? Sorry to cut you off.
Yeah.
It forces me to be more educated about healthcare.
But what about the people who don't have the resources to become more educated, or
That's a great point
that
as well.
don't have the wife, that don't have? So you're incentivizing people with more to have better care, and kind of incentivizing sicker patients or less patients with less opportunity. You're not giving them the same.
I think it forces you to do your due diligence. I think it forces the patient to be more informed about their health in return.
Yeah, I think there'll still be a disparity there.
Yeah.
I think that if we're going to talk about fixing healthcare, we have to talk about, let's start with transparency. Let's talk about fixing or controlling prescription drug costs. Let's talk about administrative complexity, right? And because that's another huge issue. We're talking about doctors. We're talking about hospitals, insurance companies. Patients spend so much, right, with so much time dealing with grievances, appeals, billing issues, claim issues. You know what I mean? So let's talk about that. Let's talk about just finally having coverage that's more stable. And I think it would, at the very least, start with those three things: administrative complexity, prescription drug costs, transparency. That's a beautiful dream.
Doesn't that open the door for that?
It could. And I'm not saying that that's impossible, but I'm just saying, realistically speaking, talking about where we are today, I think we have to start with those three things.
Fair.
Yeah, and I think to your point too, I don't think it's going to be one thing that fixes the healthcare environment.
There can't be one thing. It's too complex. It's too loaded to just say, it's almost like a simple fix. Let's talk about it this way, or let's put more on the patient. Realistically speaking, we already have a system that we're providing free healthcare to that population, right? Folks that are low income, folks that are disabled, folks that have a ton of different, health comorbidities, right? Like we are providing free health insurance to these folks. And still, these are the folks that we're having probably the most issues getting to a doctor's office. And when they do make it to a doctor's office, it's because they made it to the emergency department. And unless there's something like a fracture, a follow-up for a stroke, or infarction, which is a heart attack, or cardiac, issues of some sort, a neurology issue that requires you follow up, and they actually set you up with the follow-up physicians in hopes that they are in your network. I mean, we're still having issues with unless they do that, it's just not going to happen.
I mean, I definitely don't think it's a solution for all, but I think for most that would work, because even for those people that are in that situation, if you give them that incentive where they get that money, long term, I would think they would do what's right for their health, or they won't,
right.
And then they won't get that incentive. I don't think it's. I mean,
but then where do
again, it's the reward system that you mentioned, but on crack, like on steroids.
Right. But then we're still going to be left with a population that doesn't get care when needed. And then we're talking about death rate climbing. I mean, there's just, I think, a slew of issues come with that. I'm not saying I think it's an awesome thought or an idea, right? But I think there's still some fixes that we can talk about. And also, just realistically speaking, with where we are today, I think we have advanced quite a bit when it comes to Medicaid, when it comes to provider networks. I mean, when I was in Connecticut, I was part of this escalations department, and part of my job, or part of my role at the time, was finding pain management physicians and orthopedic physicians within the network in the entire state of Connecticut. For pain management physicians, we had 2.
That's
for
crazy.
The entire state of Connecticut. No one else wanted to enroll. I would literally go to their offices, right? I'm laying down plans, you know, in hopes that they would enroll. Listen, enroll and we'll be on your terms. And even still, it was a no, thank you. Right? Same thing for orthopedic providers. And of course, I know that it's definitely, you know, a lot to do with, you know, the reimbursement rates.
I was going to say.
But also pain management providers, and especially at that time with the opioid pandemic, or, you know, at an all-time high, right? They were just like, it's a no for me, dog. Like, I want nothing to do with it. We were getting providers arrested left and right.
Wow.
Yes. And so they became scared. They're like, you know, ugh, I don't know that I want to do that. But for the entire state of Connecticut, 2 pain management physicians, we had transportation services covered by Medicaid, transporting members from one end of the state to the very other. I'm talking about 2+ hours to get to a physician's office one way.
Wow.
Same thing for an orthopedic provider. I had children that I had to send across the border to Boston or across the border here to New York to get proper care for a fracture. You know what I mean? So I think that, you know, and one huge issue that we face as well is, you know, depending on the insurance that you switch to, if you do switch to another insurance, oh, that provider doesn't enroll, you lose that relationship with that provider. Now you're facing having to start that relationship all over again. And patients don't want to do that.
That is tough. Imagine you having a provider for 30 years.
Yes.
And mind you, there's a lot of towns where there's a provider for that town, only for that town. And God forbid your insurance says we're not going to cover that provider anymore.
It happens today.
And lose that relationship.
Yes.
There's no way that doctor can transfer all the knowledge of your family to another provider.
Medical history, man.
You know,
that's tough. I mean, you get to a point with your provider, which is why I'm so anal with providers. You get to a point with your providers that they almost, or you hope to get to that relationship with your provider that they almost know you more than you know yourself, right? And so having to start that relationship over again, that's tough, man. That's tough simply because a provider does not accept your insurance and you moved on to a different insurance. So I think that's also part of the issue. I think that's something that we have to talk about too. Let's fix that, right?
Look, I thought my idea was a great idea.
I'm a great, again, I think it's a beautiful idea. I think it's so sweet.
I really do. Because again, it incentivizes the patient.
Yeah.
It creates transparency. It's not perfect, but I think it would bring us a step closer to where things would get better.
But I think this plan would get us closer first, right? Transparency,
right?
Administrative costs.
It's included in there.
Yeah, but we clearly have to do baby steps, right? So this plan here, I think is a little bit more feasible, right? Than this one here, yours, right? Again, beautiful plan, so sweet, awesome. But realistically speaking, and with how we know how our government works,
right?
Slim to none to see that anytime in our lifetime, at least.
100%. That I don't see the government ever creating that legislation or giving away that power, or even moving the money that way. It just doesn't. I don't. It's just if I was in power, maybe.
Yeah.
I'm not gonna run. I'm not saying that I'm running. I'm just saying in a perfect world, if I could put my 2 cents in, I would make it that way where, yes, more transparency. Yes, open it up for that patients are more empowered. And in your end, since it's a separate entity, which I didn't know that it was, open it up so that I can shop around for my prescriptions as well.
Yeah.
So, and that's what, I mean, I think some of the market is starting to do that. We're seeing more in pharmacies, specifically more direct to consumer. They're going around insurance, right? To get because kind of going back to your obesity example, that's not a covered essential health benefit. Employers don't have to cover that.
Right.
So they're not, a lot of them, because it's very expensive. And I think it's like 42% of Americans qualify for medication. So they're not covering it. They're going, that's where you're seeing a lot of the compounding and stuff happening. Or you're seeing like different companies open like direct, which is direct to consumer, where you're paying the cash price, but it's a discounted cash price. You're probably paying closer to what the pharmacy or your insurance is paying.
Understood.
But it's through direct to consumer purchasing.
Why would insurance or why would insurance not pay, let's say, the GLP-1, but they would pay for what's the surgery? The stomach surgery?
Oh, the gastric bypass?
Why is that?
Money, sweetheart.
But to whom?
I mean, first of all, before you get a gastric bypass surgery, FYI, it's not just, doc, I haven't been able to lose weight. I'm tired of training on my own. I've done every diet under the sun. I am exhausted. I've been looking into the gastric sleeve or the gastric bypass surgery. I want to get it done.
But it's cheaper to get the GLP-1, no?
No, it's not.
No, it's not. Absolutely not.
Bariatric surgery is cheaper.
Yeah.
Oh, so that's why.
Well, you know what? Hold on a minute. So when you're going to get bariatric surgery or the sleeve, and you know why if you go on Mounjaro, Zipbound, Ozempic on a monthly basis, what are we looking for in terms of costs?
I don't know if I'm allowed to say
Okay.
I can, because I went on Google.
that. Okay, what does Google say?
As a matter of fact, I'm going to go to Google right now.
What was the question again?
And so how much on a monthly basis? Oh, I'm going to ask my girl right now. Come on, Google.
When they first launched, list prices were around $1,000 a month.
Right. If I were to
And they're higher
get
than that?
Zepbound from the
okay.
pharmacy and pay for it directly without insurance, how much am I looking to pay, more or less? $1,349 starting
Per month.
per month for the low dose.
Of what again?
Zepbound.
So GLP-1s?
Yep, GLP-1. So that starts you. Or Zepbound is a tirzepatide, and you are looking at starting dose 2.5 milligrams at $3.99. 5 milligram dose $4.99 or higher. By the time you are in the 15 milligram zone, you're looking at $1,349 a month for Zipbound, for a tirzepatide.
It's definitely not cheaper then.
That was me. My
Oh,
apologies.
it's okay. It's definitely not cheaper then.
No, because again, you're not, and that all depends as well. It could be because, and actually now I'm inclined to say it probably is, because you're not going to be on it. You are going to be on it semi-long term, but it all depends on the person, your weight loss goals and journeys or journey or whatever. But with a bariatric surgery, you are, and yeah, now I'm thinking about it. It is way more expensive, a bariatric surgery. But with a bariatric surgery, like I said, you're going to the doctor's office and you're letting them know, hey, I've done my research on XYZ procedure. I want to, get it. He's not just going to refer you to a specialist. The specialist is just going to evaluate you on a one-time visit and then schedule a surgery. Negative. You have to complete a psychiatric evaluation.
Right.
You have to complete a physical with your primary care physician.
Mm-hmm.
Well, that's first. Then you go ahead and get referred out to a specialist. That specialist is also going to complete an evaluation. You are going to be referred to a psychiatric evaluation. You have to do about 12 to 15 sessions, or I believe about 6 to 8 months of therapy prior to you getting said surgery, and also be okay with what comes thereafter. Low libido, potential nutritional deficiencies, all that good stuff,
Recovery.
bad stuff, recovery.
To be the devil's
maintenance.
advocate though, aren't the outcomes better with the
What outcomes?
as in you get the outcome quicker, and then in long term they're gonna have to cover less care for you?
Not necessarily.
Because don't you get healthier the skinnier you get?
Statistically speaking, and I don't have the statistics at hand, I'll be more than happy to pull it up. These folks regain the weight, and I've seen it myself.
That's crazy.
So
Because you're fixing this, but you're not fixing this. Like, this is all just because you had 15 sessions of therapy, right? That doesn't necessarily mean you're fixing your relationship with food.
Well, so then what happens? They have bariatric surgery and then they go on a GLP-1.
And then they go on a GLP-1.
So now
in
you're
turn,
paying for both.
Now you're paying for both.
And think about it, like I said, different benefits. So the GLP-1 is paying on the pharmacy benefit. The bariatric surgery is on the medical benefit.
Now
you understand.
Fucking money.
Listen,
Guys, I'm going to have to cut it short. Look.
short.
We
2 hours later.
Look, for this topic, this is short.
Yeah, true.
I was so optimistic. I thought I was going to solve the solution.
Did you really think you were going to solve healthcare?
I thought look,
Go ahead for the cheek.
what I proposed, I think pushes us towards a better system of healthcare.
It was all a dream. Well, yeah, I mean,
You don't agree with me? It's okay. You don't have to.
no, I again, I think it's a beautiful plan.
If we were to
just
do what I
don't-
propose, do you think it'll get better?
I think it would get better for some.
Majority.
I'm a good 60-40, 60 no,
In
40
10
maybe.
Let's say 10 years.
yes, sir.
In 10 years, would you say do you don't think that we will have a healthier country?
I need a trial period.
Really? I could agree with you to a certain extent because I don't think people would follow it. They don't have the discipline for it. But I do want to incentivize the people that do what's right for their health.
You might want to mute that because it's probably going to start talking on the live
It's
or
okay.
whatever.
I'm about to cut it.
Okay.
But yeah, I was optimistic about it, and I thought my idea was amazing.
It is a beautiful idea. It was all a
So
dream.
yeah,
Bring it to your legislator.
right.
Yeah. And then let's have them on the podcast.
Look, for what
how
it's
that goes.
worth, thank you for sitting with me so long for these 2 episodes, and we'll look into convincing you guys to have a third part. I think we should at this point. There's a lot that we haven't
This could be
covered.
a 10-part series.
We definitely
totally
didn't cover the part where I feel that us as first generation Americans.
Well, there's your part 3.
Right. I'm not even gonna say it. So
But I'm gonna say, there's
stay
your part
tuned.
3.
Stay tuned, and you'll see what we talk about for part 3.
For part 3.
Love you guys. Bye.
Bye.